Hi, ma'am. With your permission, shall we start, ma'am? Hello. Hello. Am I audible?
Yes, sir. Yes, sir. Chitrakla here.
Yeah. Hello. Oh, madam, with your permission, shall we start, ma'am?
Yeah, sure. Yeah.
Okay, ma'am. Good evening, doctors. I'm Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I kindly request all the participants to post their questions in the comment box, and at the end of the webinar, we'll have a short Q&A session. And good evening, Dr. N. Suvidha, ma'am. Thank you for accepting our invitation. It's an honor to introduce you, ma'am. Actually, madam, don't need any introduction. She's currently working as a civil assistant surgeon in the Department of Obstetrics, Andhra Medical College, Visakhapatnam. And she did her medicine from Usmania Medical College and MS from Gandhi Medical College, and received the Best Physical Officer Award, State and District, and received Rashtrapati Award and Raja Puraskar from for social services. And her area of interest is high risk pregnancies. With this, I welcome you, ma'am, and thank you for accepting our invitation. And over to you, ma'am.
Yeah. Thank you, Dr. Somesh. Very happy to receive this invitation. And today we'll be speaking about hypertensive disorders of pregnancy. Hello? Yeah. Yeah. Hello?
Yes, ma'am, we can hear you, ma'am.
Yeah. Yeah. So good evening, everyone. Today I'm going to speak about hypertensive disorders of pregnancy. One of the important medical complications in pregnancy, and why we so concerned about it, because it amounts to greatest number of greatest number of maternal mortality, probably next to hemorrhage and sepsis. And so we are really concerned about this issue. So in this talk of mine today, I would be speaking about the epidemiology, categorization of hypertensive disorders, pathogenesis, a brief review, risk factors and clinical features of hypertensive disorders, and then investigations and management. And finally, there would be a word on how do we predict and how do we prevent it. And throughout, I would be adding the recent reviewed guidelines, and these guidelines are from NICE. It has been reviewed in 2019 August. Now, coming to the definition, as we have all known, hypertension is defined as a systolic blood pressure which is recorded as greater than 140 millimeters of mercury, greater than or equal to 140 millimeters of mercury, and a diastolic pressure greater than and equal to 90 millimeters of mercury. It is and or, that means either an isolated systolic blood pressure raise or an isolated diastolic blood pressure raise, and this has to be measured 4 hours apart. Now, as we have discussed, this is one of the leading causes of maternal deaths globally, and it complicates about 2 to 10% of all pregnancies, and almost an estimated 50 to 60,000 deaths occur worldwide due to pregnancy-related complications. That could be the PPH, that could be DIC, or CVA or CCF, but it accounts to about 50,000 to 60,000 deaths per year. And the incidence is definitely higher in developing countries as compared to developed countries. Now, according to the recent guidelines, the hypertensive disorders in pregnancy have been categorized into 4 categories. The first category is chronic hypertension. And here, when I say hypertension, the definition remains the same. That is, the systolic blood pressure greater than or equal to 140 and diastolic blood pressure greater than or equal to 90, which is measured 4 hours apart. So in chronic hypertension, the lady has already been diagnosed as a hypertensive. That is, she has been on medication before pregnancy, or she has been diagnosed as hypertensive for the first time before 20th or 20 weeks of pregnancy. And going in the line, then we have chronic hypertension with superimposed preeclampsia. Here the patient or the lady who's a chronic hypertensive develops proteinuria for the first time in pregnancy. Then we have gestational hypertension. This is hypertension without proteinuria developing after 20 weeks of gestation or during labor, and it resolves within 12 weeks postpartum. Then the last one here I've shown you as preeclampsia and eclampsia. Both of them come under same spectrum, that is preeclampsia, eclampsia syndrome. And this is gestational hypertension associated with proteinuria. And when there are convulsions along with this, we classify it as eclampsia. A small note on health syndrome: hemolysis, elevated liver enzymes, and low platelets. The name itself is self-explanatory, and this is one of the complications of preeclampsia and eclampsia syndrome. The same thing, it's been shown on the chart. Before 20 weeks, it is chronic hypertension. After 20 weeks, it is gestational hypertension with proteinuria. It classifies as preeclampsia, and with convulsions, it classifies as eclampsia. Now, risk factors. So a mother walks in at your clinic, and seeing her, what are the red flags which raise that she might be a higher risk? She might be at a higher risk of developing gestational hypertension and preeclampsia. First thing, obesity. Obesity greater than 35, BMI greater than 35 is definitely a very, very, very important high risk factor. Then a primiparous lady, or new paternity, or extremes of age group, that is adolescent pregnancy or age greater than 40 years, previous history of gestational diabetes, diabetes mellitus, hypertension, renal disease, or a patient who has previously had a kidney transplant, a lady with a twin gestation or a multifetal gestation, and previous history of preeclampsia. All these factors place the lady as a case of high risk. Now, then coming down to pathogenesis, as we all know, pathogenesis is, we can describe it as a 2-stage disorder, wherein first stage is with the placentation. What is abnormal? We call it as poor placentation. Why? Because the syncytial trophoblast failed to invade the spiral arteries and failed to convert them into low resistance sinuses, because of which there is a decreased blood flow to the placenta, causing placental ischemia. Because of the placental ischemia, what we have is oxidative stress, and therefore there are release of cytokine factors causing endothelial dysfunction. And when we speak about cytokine factors, what happens is there is an increase in thromboxane A2 production and decrease in prostacyclin production, and therefore there is a net vasoconstriction which happens. Now, because of all these, what happens is there is a decreased, as we have discussed, because of all these cytokines, what happens is there is a poor renal perfusion leading to hypertension, proteinuria, and edema. And if this left untreated, the patient develops severe hypertension. She might as well go into a DIC and might end up with eclampsia. Now, since we are discussing the pathogenesis, I would want to add a note on aspirin here. This is the latest recommendation. Addition of aspirin 75 to 150, it is not 100, it is 75 to 150 milligrams. And if started as early as 12 weeks in cases having 1 high risk factor or 2 moderate risk factors. And when I say high risk, there are 5 things which quantify as high risk. First is the lady has a history of hypertensive disorder in her previous pregnancy. Second one is chronic renal disease. Then a case of autoimmune disease like SLE or APLA, a case of chronic hypertension, and a case of type 1 or type 2 diabetes. These 5, categorize as high risk cases, and a lady having any of these risk factors will definitely be benefited by starting aspirin, irrespective of anything else, as early as 12 weeks in a pregnancy and not later than 20 weeks. So the best benefit is at 12 weeks. You can as well start it till 20 weeks, but after 20 weeks, it wouldn't be of greater benefit, because the main pathology lies at secondary invasion, wherein the cytotrophoblasts do not invade, and therefore the spiral vessels are not converted into low resistance sinuses. So at that, the secondary invasion occurs at 12 to 16 weeks, and therefore that is the right time to start aspirin. 75 to 150 milligrams, you can as well base it as on weight, that is 1 to 2 milligrams per kg body weight. And other moderate risk factors are primigravida, a 40-year-old or above, a pregnancy, inter-pregnancy interval of greater than 10 years, BMI greater than 30 at booking, a family history of preeclampsia, and multifetal gestation. Now, this accounts to secondary level prevention. Now, there have been many studies stating use of calcium, magnesium, folic acid and stuff, but the studies or evidence has proved that there is not much use of magnesium, folic acid and antioxidants. They are not effective. Calcium can be useful in cases or in settings of low dietary calcium intake. In those cases, supplementation of calcium might be useful, but the best thing we can do in secondary prevention is start aspirin as early as 12 weeks. Now, moving on to the management, what are the treatment objectives? When you see a case, you diagnose it as gestational hypertension, what are you aiming at? First thing is you need to stabilize the hypertension, then prevent the progression of disease and prevent complications. The progression of disease is to prevent progression to severe preeclampsia and prevent occurrence of eclampsia. Then to avoid all the damage which can happen to the mother, like the end organ damage, that is kidneys, patient might end up into ARF, liver failure, and these stuff. So you have to control the disease so that there is no gross morbidity to the mother in future. Then you have to deliver. Doing all this is one step, but you have to give the mother a healthy baby. So how do you optimize? What is the timing of delivery in each case? That is what is important. And then after delivery, you restore the health of the mother in puerperium. So these are the treatment objectives. Now, what are the complications? Why are we so worried? What are the complications? First, the mother might develop severe hypertension. What is severe hypertension? Hypertension or recordings greater than 160 systolic and or 110 diastolic comes under severe hypertension. Then eclampsia, definitely, HELP syndrome, abruptio placenta, DIC, liver infarct, pulmonary edema. Because there is a hypercoagulable state, then you have CVA or CSVT, that is cortical sinus venous thrombosis occurring. These are all complications which can occur in mother. And in fetus, there can be prematurity because you might have to deliver the baby earlier to save the life of mother. Then because of the decreased placental blood flow, they can be IUGR, and they can even be a fetal death because of IUGR or fetal distress. Now, how do we investigate the further? A patient comes to you, now we have diagnosed that she is a case of hypertension, whatever it is, chronic hypertension or gestational hypertension. So at diagnosis, what do you do? First thing is counsel the patient. Tell her what it is, tell her how should we go about, and then order for these investigations. What investigations are we looking out for? Basically, why are we doing the investigations? We are doing investigations to find out, to have a baseline and to find out if there are already any complications which have set in, right? So the complications, as we have discussed, are HELP syndrome. So if I had to rule out, what we need is a platelet count. So you go for a full blood count with full blood picture with platelet count. Then you want to rule out, you want to have a baseline creatinine level and to rule out, ongoing kidney damage. Therefore, you go for a renal function test and liver function test to rule out HELP and also to have a baseline enzymes. Then proteinuria. Proteinuria is one important thing, though, to segregate it as gestational hypertension or preeclampsia. So previously 24-hour urine protein was 24-hour urine protein was considered to be gold standard, but according to the 2009 revised NICE guidelines, dipstick, quantifying proteinuria with dipstick, and also taking spot, protein creatinine ratio or albumin creatinine ratio is as well good enough as 24-hour urine albumin proteins, right? Now, as we all know, dipstick 1 plus is 3.3 grams, 2 plus 1 gram, 3 plus 3 grams, and greater than 5 grams come under plus 4. And when you're taking protein creatinine ratio, it should be greater than 30 milligrams per millimole is considered abnormal. And if you are considering, that is abnormal. Now, coming to each entity in difference. First is chronic hypertension. So chronic hypertension, your job is half done when she has already been diagnosed as a hypertensive. So if she is already diagnosed as hypertensive, and if she has that information that there are some drugs which have to be changed before she is planning a pregnancy, she would definitely come down for a pre-pregnancy counseling to you. So when she comes down for a pre-pregnancy counseling, what do we do? First thing is, we want to find out on what drugs is she on, and to change the drugs to pregnancy friendly drugs. Generally, if they are on AC inhibitors or angiotensin receptor blockers, we recommend her to change her drugs to calcium channel blockers like nifedipine or labetalol or alpha methyl dopa, whichever is most suited to her. And then we would want her to optimize her pre-pregnancy weight, because a greater BMI will definitely put her at a higher risk of developing complications. And then these are the cases which might benefit from salt restriction. Not all gestational hypertension cases, but cases of chronic hypertension will definitely benefit from salt restriction. Next. Now, since we are talking about chronic hypertension, a small note on the etiology. Most common is essential hypertension. Then other causes are secondary hypertension. And these secondary hypertension includes, it could be renal cause, it could be an endocrine cause wherein there can be a pheochromocytoma or a Cushing syndrome. And then vascular causes like aortic coagulation. Okay. Then systolic hypertension, wherein you might have a thyrotoxicosis like condition. Now, coming on to management of chronic hypertension. So you record the blood pressure and see what is the blood pressure. If the blood pressure is less than 150 by 100 and there are no other risk factors like we have discussed previously, then and the patient is stable, then you can continue outpatient management. And if she remains asymptomatic with the properly controlled BP, you can as well deliver her at term. That is the first thing. Second thing, if a BP is less than 150 by 100, but there are risk factors like the patient is obese, or she is a primipara, or she is having multifetal gestation, then recheck the antihypertensive treatment, check if the dose is being sufficient or not, and see if her drugs are see that her drugs are changed to either beta blockers, calcium channel blockers, or alpha methyl dopa, and then advise self-monitoring of blood pressure at home. And her antenatal visits should be once in 2 weeks. Then you check for fetal growth right from 24 weeks. You check for fetal growth with ultrasound every 3 to 4 weeks. And depending upon the results, you actually monitor her more frequently. Probably you can go for a Doppler once in 2 weeks if the results are not, up to the mark, or the growth is not up to the mark. You ask for a uterine artery, middle cerebral artery Doppler right from 28 weeks, and this is repeated once in 2 to 3 weeks. Any point of time during this monitoring, if the patient develops complications or if the patient is unstable, you admit her to the hospital. When I say unstable, that means she has developed superimposed preeclampsia and chronic hypertension. It is the point where the patient needs admission, further evaluation to decide on timing of delivery. Now, next coming to gestational hypertension, which is very common, quite common, occurs in around 2 to 10% of population. Previously, when we were managing gestational hypertension, it was divided as mild, moderate, and severe. Now that is gone. You have hypertension and severe hypertension. What is severe hypertension? As we have discussed earlier, it is blood pressure greater than 160 by 110 of mercury. 160, 110 is the cutoff where you call it as severe hypertension. So your management depends upon your initial blood pressure recordings. You have recorded the blood pressure to be around 160 by 110. So what do we do? You first admit the patient. Now I'm discussing about management of severe hypertension, severe gestational hypertension. You got to admit the patient. Admit the patient and see that her BP falls below 160 by 110. And once it is controlled, then you manage her as normal hypertension. Okay. You always, now the funda is you should all do not aim for a drastic fall in BP, or don't let her go into hypertension. Aim for a fall in BP, and that should be at a range of 135 to 85, and that is according to revised NICE guidelines. So how often do you monitor a BP? Once she has come to you with a BP recording of 160, 110, admit her, monitor a BP every 30 minutes until it falls below 160 by 110. Once she is admitted and she is kept on drugs, definitely daily monitoring of BP once or twice a day is important. Now, as we have discussed, again, we go for all the the basic PIH profile to have a baseline and to find out if there are any other complications happening. And these are the candidates where NICE recommends carrying out placental growth factor based testing, to find out if she is a high risk candidate for preeclampsia. Now, when it is a normal hypertension, the BP is around 140 to 160, 90 by 190 to 110. You do not have to routinely admit her in hospital. Or if it is greater than 140 by 90, you start her on antihypertensives and ask her to have her blood pressures recorded. She can come down to you, or she can get it done at her local GP. Have a record of her blood pressure once or twice a week and see that it is falling below 135 by 80, and ask her to come back to you if at any point of time it is, the blood pressure is above 140/90. And here you ask her to get a urine dipstick done once or twice a week. And here all the blood tests are repeated once a week. So she comes to you every week. Meanwhile, she has twice BP recording at her home, and a urine dipstick is done twice at home. So you alert her to come back to you when the BP is raising, or when there is proteinuria which is recorded, or raised proteinuria, or if she is having any premonitory symptoms. A small note on antihypertensives. Now, the 3 classical drugs which NICE or RCOG prescribes are, first is labetalol. Labetalol, as we all know, is a beta blocker with a mild, which has mild alpha-1 blocking action. And that is the best drug of choice until unless contraindicated. Contraindications being any respiratory tract, limitations or asthma. And the dosage, as we all know, starts from 100 milligrams and can be raised to 400 milligrams given thrice a day. So maximum dosage can be raised up to 2400 milligrams. Very few side effects are noted with labetalol, and among them, bradycardia is one, bronchospasm is another one. These 2 are the important side effects which you need to keep in mind. So, a case having baseline bradycardia cannot be given labetalol. Such cases, you can consider giving nifedipine. Nifedipine, which we have all been using for ages. There are 2 things. First thing, never give nifedipine sublingually. Second thing is sustained release formulations are always preferred over plain nifedipine. So, Nicardia retard or sustained release ones are preferred. And dosage starts from, since it is sustained release, is given twice a day, and it can start from 10 milligrams BD and can be raised up till 30 milligrams BD. That is 60 mg to 80 mg in a total can be given. Now, what are the side effects with nifedipine? First thing, the patient complains of headache, which generally gets settled within 21 to 2 days. Then patient will have tachycardia, sometimes pulmonary edema, and she might as well complain of constipation. When these two drugs are contraindicated, only then we go for alpha methyl dopa. And here the dosage is around 250 milligrams, which is given once in 8 hours. Action is centrally acting. What are the problems with alpha methyl dopa? TID dosage, depression is one thing, and then sometimes she might have problems with vision. She might have blurred vision, and it has a very slow onset of action, and therefore labetalol and epinephrine are always preferred over methyl dopa. Now, so gestational hypertension, moving on to the next problem, that is preeclampsia. This is where timely intervention will save the life of the baby and mother. This is where you have to catch hold of the patient, give her proper care, and decide on when you have to deliver her. Again, in preeclampsia, you have two things: preeclampsia. Preeclampsia, any case of preeclampsia, you need to admit her to the hospital. And how much time you want the patient to be in hospital, you want to continue her in the hospital till birth, or all depends upon the severity of preeclampsia, that is the severity of hypertension and other symptoms and biochemical investigations, right? So once you have admitted a case of preeclampsia to hospital, you measure the blood pressure. If the blood pressure is, as we have discussed, if it is greater than 160 by 110, we measure it every 30 minutes till it falls below 160 by 110, and then you monitor her blood pressure every 6th hourly, that is 4 times a day. But initial blood pressure, if the initial blood pressure is less than 160 by 110, you can as well admit her, put her on oral drugs, and then you can monitor her her BP once in a day. Then how often do we do a urinary dipstick examination? Just once when she's admitted. You repeat it only if there are any new clinical symptoms which have come down, or in any other signs of progression of disease. Only then you go for a repeat dipstick. Now, blood test. In gestational hypertension, we are doing a pH profile once in a week. But when it comes to preeclampsia, without severe features, you repeat it twice a week. And if it is preeclampsia with severe features, and you are planning for an expectant management, they are repeated 3 times a week. Management of preeclampsia. The management of preeclampsia largely depends on the gestational age and the blood pressure of the patient at admission. So if the gestational age is less than 32, with the initial assessment, everything is normal. Then everything is, you have admitted her, you have assessed, the initial BP is less than 150 by 100, and on pharmacological therapy, the BP is around 130 by 80. The proteinuria is less, that is around 2+, with no other signs, that is no other signs of fetal compromise. The biochemical investigations are absolutely normal. You can as well put her on outpatient management. But you ask her to get her BP checked once in 2 days, and dipstick should be done once in a week, and she has to come back to you every week with all the records. Then every week you monitor the patient for any progression of the disease. But at admission, you find any of these risk factors with, IUGR could be there if there is oligohydramnios, or the Doppler indices are a variable, the biochemical features are variable, that is you have the platelet count is less than 1.5 lakhs, or the LFT is RD range or at a higher level. In all these cases, you have to admit the patient. Continuous assessment is required every day. And here we get all the investigations, as we have discussed, done twice weekly, and you monitor for fetal growth once in 2 weeks. And if there is IUGR which is set up, you monitor with Dopplers every week. Provided all these remain stable, you prolong the pregnancy till 37 weeks, and at 37 weeks, this is the time when you deliver the patient with preeclampsia. In gestational hypertension, you can deliver the patient at 40 weeks, but never allow it to past dates. In cases of preeclampsia, expectant management when the maternal condition is good continues till 37 weeks, and you deliver her at 37 weeks. But at any point of time, a condition of mother deteriorates, you deliver her. that is between 32 to 36 weeks. You give her a cover of steroids, prophylactic magnesium sulfate is given, and you require to deliver her. Now, again, a small note on severe preeclampsia. Severe preeclampsia, if it is less than 24 weeks, when diagnosed at less than 24 weeks, no point in expected management. You have to control the blood pressure and deliver her immediately. And here, this is a case. Severe preeclampsia is the scenario wherein you put on magnesium sulfate apart from IV antihypertensives, right? Then, if the gestational age is between 24 to 34 weeks, the initial assessment, as we have discussed in preeclampsia, is done when the BP is controlled and all other things, that is, maternal factors and fetal factors, are under control. You admit the patient till delivery, she is with you, then you monitor her daily. And if it is stable, you continue expectant management up to 34 weeks if it is severe preeclampsia. At any point of time when the maternal condition starts to begin to deteriorate, that is the time you give again a dose of magnesium sulfate and immediately deliver her. If it is 30, when at presentation, if she is greater than 34 weeks, then that is also an indication for immediate delivery. You give a magnesium sulfate dose, blood pressures are controlled, and initiate steps to deliver the patient quickly. So gestational hypertension, deliver her at term, that is 38 completed weeks. If it is preeclampsia, deliver her at 37 weeks. And if it is severe preeclampsia, greater than 34 weeks, deliver her immediately. Less than 24 weeks, deliver her immediately. And between 24 to 34 weeks, if the patient's mother's condition is stable, you can have an expectant management under your care. Now, a small note on the IV drugs which can be given in hypertensive emergencies. We at our hospital routinely use labetalol. Labetalol given as 20 mg IV bolus. Check her BP after 20 minutes. If it is not controlled, then we give 40. Again, then 80 and 80. That is a maximum dose. A total dose of 220 milligrams mg is given. If labetalol is not available, Depin can be given. 10 mg per oral is given stat. Again, you repeat BP after 30 minutes and again give a 10 mg. And here, generally, we use short-acting nifedipine is not, recommended. Use of short-acting nifedipine is not recommended. Most of the times with the labetalol, the BP gets controlled. But if BP does not get controlled, the next resort is hydralazine. And hydralazine is given as 5 mg IV or 10 mg IM. And this dose is repeated at 20 minutes intervals if there is no response. And when you're giving hydralazine, see that, the mother is not dehydrated, because it might as well cause sudden hypotension. Now, this is what this slide shows, the labetalol flowchart as we have discussed. Last one, that is management of eclampsia. That is the dreaded complication, management of eclampsia. Patient comes to you with a eclamptic fit. As we all know, you first stabilize the patient, airway, breathing is seen. Then first is control of seizures. How do we control of seizures? Any seizure in pregnancy should be treated as eclampsia. And the drug of choice, what we use is magnesium sulfate. Then once you start magnesium sulfate, then start drugs to control hypertension. Once the patient is stabilized, it is the time to deliver. So this has to be the sequence: control of seizures, control of hypertension, and then deliver the patient. Now, magnesium sulfate regimen, as we all know, either you can give an IM regimen, that is Pitchard's regimen, wherein 20 mg 4 grams dosage is given, slow IV, and it should be given, over 5 to 7 minutes. Sit beside the patient, slowly inject the drug. Once it is given, the loading dose contains of IV and IM doses. IM doses 10 mg with 10 grams dose, 50% of weight by volume. So you give 5 grams in one buttock and 5 grams in other buttock, and trust me, this is really, really painful. So always give 1 ml lidocaine with it. So this is the loading dose. Once loading dose is given, then you go for maintenance dose, that is IM dose. In Pitchard's regimen, we give an IM dose, 5 grams, 50% every 4th hourly in alternate buttock. And what we are using now is Suspens regimen. Suspens regimen, we give a loading dose of 4 grams, 20% IV. and then immediately start a maintenance dose at a rate of 1 to 2 grams per hour, wherein we go dilute, we take magnesium sulfate, dilute in a 500 ml of NSRL, and then we put it at a rate of 50 ml per hour. That is delivering of 1 gram per hour. And this should continue for 24 hours if you're not planning to delivery. Now, or if it is eclampsia, you're delivering her, that should be continued 24 hours after last fit or 24 hours of delivery, whichever is later. And a small note on how do we monitor on magnesium toxicity. We have to check out for her urine. We have to check for her urine output, her respiratory rate, her knee jerks. And these three we should check out. Why do we check out for urine output? Because it is excreted through urine. And when there is a decreased urine output, there will be accumulation of magnesium causing hypermagnesemia. And in case you're suspecting magnesium toxicity, the antidote which we all have is calcium gluconate, which can be given as which is available as 10% solution, and it is given as IV. Timing of delivery, as we have discussed, gestational hypertension at term, mild preeclampsia at 37 weeks, severe preeclampsia at 34 weeks, and eclampsia as and when the patient has thrown fit, irrespective of gestational age. And if you are delivering the patient earlier before term, you give an intramuscular dexamethasone. That is 6 milligrams 6th hourly, which 4 doses, or 12 milligrams 12th hourly, 2 doses. So how do we deliver? You induce or you go for a cesarean section. Cesarean section is not the rule. We actually go for a cesarean only when there are obstetric indications for it, like a CPD or a malpresentation or a malposition, or cases which require urgent termination, but the cervix is really unfavorable. The induction delivery interval would be quite prolonged. Or in cases of abruptio, wherein you have identified the abruptio just at that point of time, and the baby would survive if you take out the baby immediately. In such cases only we go for a cesarean section, or else we go for induction of labor routinely. Then, once the patient is delivered, how do we manage her postnatally? So postnatal management issues will be, how do we continue the antihypertensive drug? What should be the target BP? And how often should she come back to you for, review? And how often should we do her blood tests? So if it is gestational hypertension and patient is not on any antihypertensive, just monitor BP once a day. And if it is only greater than 150/100, you start an antihypertensive. A case of gestational hypertension who was already on hypertensives, monitor a BP once a day for first 2 days, and again between 3rd and 5th day. And depending upon the hypertension, if the BP is greater than 140/90, only then you put on antihypertensive. Preeclampsia 4 times on the first 2 days, alternate day for 2 weeks. And if at all the patient was on alpha methyl dopa, definitely switch the drug to either labetalol or nifedipine, or if it's a case of chronic hypertension, you can as well switch her back to ACE inhibitors. Now, measure then. When do you, a case of preeclampsia, when do you measure platelet counts or, transaminases? They have to be measured 48 to 72 hours of the body. You don't have to immediately repeat it. Do it on the 2nd or 3rd day. And if they are normal, please do not repeat them again. Okay. Then when do you call her back for review? She can have a review at her place after 2 weeks, get a BP checked. And if everything is normal, she can have a review at 6 to 8 weeks with a physician. Okay, all done. Now you're sending the patient home, right? So one thing she would be asking definitely for sure is, doctor, what is the chance that I will be having these complications again in my next pregnancy? So if the patient, in present pregnancy, in current pregnancy, the patient has gestational hypertension, the chance of she having gestational hypertension is around 11 to 15% in next pregnancy. That is 1 in 7 women with gestational hypertension can have a repeat. Then now the patient is having preeclampsia now. Her chances of having gestational hypertension is almost similar, 1 in 7, but her chance of having preeclampsia is higher. This is 1 in 6, right? And chronic hypertension, she should definitely be very cautious. Ask her to finish a family as early, within 4 or 5 years, so that with age, problems of chronic hypertension definitely increase. Now, the last topic now, a small note on predictors of preeclampsia, which has been, so much, which has been such an in topic, how do you predict for onset of preeclampsia? Most important predictor is identifying risk factors at the first visit. This is the best predictor. And once you have identified what you can do, only thing you can do is to prevent the start off on aspirin, right? You started off on aspirin. So as we have discussed, chronic hypertension, pre-gestational diabetes, connective tissue disorders, obesity, GDM, previous GDM, age greater than 40 years, limited sperm exposure, all these are risk factors, and they increase the risk of preeclampsia by almost 10 to 40%. And in cases of previous pregnancy having adverse pregnancy outcome, that is abrupt show, IUG or IUFD, the chance of having preeclampsia increases by 2 to 3-fold. Now, then moving on to the tests, there are so many tests which are coming up now, but I swear practically not many of them are which we actually use. Probably the single best thing which most of us are using now are, we are trying to find out on a Doppler ultrasound persistent of early diastolic notch or increased PI value in the uterine artery Doppler is one of the screening tests, which is very easily available. We can get it done with a T-second trimester scan. And its predictive value is around 40% when it is done individually. This can as well be combined with the placental growth factors, that is what NICE recommends. And these placental growth factors based tests include serum placental growth factor, which is reduced, then soluble FMS like tyrosine kinase, which is elevated, and endoglins are elevated. Doppler ultrasound with conjunction with any of these tests will definitely give you a better predictive value. Now, as we have discussed, maternal serum uric acid, the predictor test, maternal serum uric acid levels are generally high. And when you're doing a second trimester scan, a raised alpha fetoprotein or HCG or inhibin will be one of the red flags. Then reduced placental growth factors are seen. And also something called delta hypertension or white coat hypertension, mid-pregnancy blood pressure measurements. And if they are, high normal, definitely see and follow up the patient that she might be ending up getting gestational hypertension. Then uterine artery Doppler determinations. As we have discussed, elevated SFLT and endoglins. Then this is what urinary calcium excretion. You have hypocalciuria, which is seen. And that's it. So these are all proposed methods for prediction of preeclampsia. Last one. So long-term risk to the mother. The mother is definitely exposed to a risk of, as she has a higher incidence of, CVD, cardiovascular disease, CAD, and stroke. And this is more increased with preeclampsia, and also patients who are having small for gestation age and preterm delivery. The odds of a patient having these after 10 years of delivery is particularly increased as compared to normal women. So last one. So with my talk, the points I want to focus is, first, please always do a risk assessment, and that is a single thing which we can do to benefit the patient, and start her on low-dose aspirin. Then always antenatal plan should be individualized according to a patient and patient symptoms. Early identification of worsening of symptoms, and this can be done by thoroughly counseling the patient about what she has to look out for, and see that she is compliant with her medication, and ask her to report to you whenever she finds out these symptoms. And timely interference and use of predictors for preeclampsia will definitely help us, to reduce the mortality, maternal mortality due to gestation hypertension. Thank you.
Thank you, ma'am. Thank you for the very excellent and superlative talk. Madam, if you allow me, then we will have a Q&A session. I'll read the questions for you from the comment box.
Yeah.
Madam, we have first question that is, What is the treatment of resistant hypertension during pregnancy?
um, Resistant hypertension is hypertension when it is not controlled by all three drugs which we have discussed. That is, the patient is using drugs, the labetalol, dipin, and alpha methyl-dopa. Even then, when the hypertension does not reduce less than 160 by 110, then that is a patient which has to be, hospitalized, monitor her for, if she's somewhere near, period of viability, monitor her closely. And once there are, the complications set in, then you have to give her a dose of steroids and deliver her.
Thank you, ma'am. And we have one more question. Fluid management in eclamptic patient.
Yeah, right. So preeclampsia, in eclampsia, first thing is, please never dump her on fluids. So you have to restrict the amount of fluids which you are giving her. So it should be given, if at all, given as a lifeline, that is less than, around 70 to 80 ml per hour. That is what you give. And then within, once the patient comes to you with eclampsia, you have to deliver the patient within 24 hours. Literally by 24 hours, she will, and at new guidelines, it is 12 hours, the time limit. And definitely do not dump her on with the fluids. And second thing is, please do not use diuretics, that is Lasix, until unless you have found out that her lungs are loaded with fluid and there are so many crepitations. Only then you give her Lasix, and do not give Lasix, that is diuretics, antinetal.
Thank you, ma'am. We have one more question. That is dietary modifications in preeclampsia pregnancy patient.
Yeah, dietary modifications, as we always, prescribe. First thing is, a proper protein rich diet. Limit your carbohydrates. The traditional thali model is there, wherein, so 40% carbs, 30% proteins, and 30% of fats. That is the diet which we recommend to everything. Second thing is, do not offer salt restriction. It according to evidence, it has really no role, or does not really help any case of gestational hypertension. And third thing is, supplementation with fish oils or antioxidants have not shown any effect in curing or treatment of gestational hypertension.
Thank you, ma'am. We have one more question. Calcium supplementation on preeclamptic patients.
Yeah, calcium supplementation in preeclamptic patients is useful only in cases where they're proved to have a low calcium diet. Only in those cases it is useful. But in other cases where the patient is routinely taking her normal calcium and she is not deficit, her food is not deficit in calcium, it really has no role. But as a benefit of doubt, you can as well give. Generally, we give them 500 mg once a day. Here you can go for 1 gram a day.
Yeah. Thank you, ma'am. Ma'am, I don't find any further questions.
Yeah.
Then if you allow me, then we will close this webinar.
Yeah. Sure, Sumendra. Thank you for giving this opportunity. Thank you, Sheet Connect. Thank you.
Yeah. Thank you, ma'am. Thank you for giving us your valuable time. And it was a very, very detailed and superlative talk. Thank you, ma'am. Thank you very much. And I thank all the delegates for participating in this webinar. Many thanks from the Shield team.
Thank you.
Yeah. Thank you, ma'am.